Good morning, everyone. I'm Dr. Tara Karen. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Mehalay Kuminen, to introduce the session. Mehalay?
Thanks, Tara. Good morning and welcome, everyone. I'd like to just take a moment to thank our panelists for being here. And just a quick reminder, this is a Maine Pro accredited session and you'll receive more detail by email. Next slide. So I'd like to move on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Neutral people. Tara, back to you.
Thanks, Mehalay. As we do these land acknowledgements, I always try and reflect myself on injustices past and present, and have also recently been reflecting on my own way of seeing the world and how even in the way that I think about primary care in some ways is very colonial, and looking forward over the next few months to learning more from some of my Indigenous colleagues around Indigenous ways of knowing and Indigenous models of care. So shout out to my colleague Janet Smiley, from whom I'm continually learning. Next slide. I wanted to just remind everyone that these are a series of sessions that build off one another. So if you're interested in looking at past sessions, or if you wanted to look at the slides, recording resources from today, just visit our website. And a huge thanks to our planning committee who works hard to pull these sessions together. We're always looking for new planning committee members. So if you're interested in that, please contact us and we'll also provide an email so you can do that at the end of the session. So I'm delighted today to welcome a wonderful set of panelists that we're going to hear from. I'm going to turn it to them one at a time to introduce themselves. Allison?
Good morning, everyone. I'm Allison McGeer, Adult Infectious Diseases at Sinai Health System. And you see my conflicts here. I do a lot of work with both vaccine companies and companies that are developing antivirals for COVID and other respiratory viral infections. Thanks.
Farine?
Hi, good morning, everyone. Thanks so much for having me. So I'm Farine Karachuwala. I'm a public health and preventive medicine specialist and family doctor. So I currently work at the Ministry of Health as one of the Associate Chief Medical Officers of Health, and also work as a family doctor with Inner City Health Associates, where I'm also the board chair.
Thanks, Farine. Mohammed?
Good morning. I'm Mohammed Al-Raki. I'm a family doctor in Kitchener-Waterloo, and I'm managing director of the eHealth Center of Excellence, which is a not-for-profit organization.
Mehalay?
Hi, everyone. My name is Mehalay Kuminen. I'm a family physician in Cambridge. I also am the president of the OCFP, and I serve as a chief of family medicine at the Cambridge Memorial Hospital. I receive a stipend for both of those last two roles, neither of which poses a conflict today.
And I'm Tara Kieran, and I've just listed some areas where I've gotten some grants or salary awards or speakers honoraria, and none of them I think pose a conflict for today's talk. Next slide. So as usual, this session is really unique because of your interactivity, and so we just reminder to put your questions in the Q&A and then use the chat to interact with each other, share your own resources, your thoughts, your comments. We always love to hear those. But if you put your questions in the Q&A, that helps us keep track of them. And please, instead of putting your own question in your own words, if someone else has written something that's like what you want to ask, it's best to give that the thumbs up, because we'll be prioritizing the questions that have the most thumbs up. Next slide. So today we're going to start by hearing from Dr. Allison McGeer, who's going to give us an update on where we are with COVID, what we might expect over the coming months or year. And then we're gonna talk about vaccines in more detail. And then Farine is gonna build on that by talking about kind of where we are in Ontario and what our current kind of policies are in Ontario, how you should be, which patients you should be really thinking about reaching out to who haven't gotten a vaccine yet. And then following that, we're going to break for some Q&A, and then we'll come back to Mohammed, who's going to go over some really useful digital tools to help to make your practice easier. We know this is a really trying time for everyone, and we hope that this will be a really practical session. So with no further ado, I'm going to turn it over to Dr. Alison McGeer.
All right, I'll come off mute. Didn't take long to do that today. Good morning again, everyone. Okay, so let's start with where we are in the season. You see here one each of the surveillance systems we have in Canada for looking at what's happening to the season. And you can see on the left-hand side of this that the influenza AH3N2 season is fundamentally over. There's still a few cases, but not very many left, which is nice and takes a lot of pressure off both offices and hospitals. So a lot of anxiety on Twitter about whether we're going to see influenza B coming. And, we're all anxious at this stage, but it would be, I think, distinctly unusual. And so far, there's no evidence that it's happening. So you need to keep your fingers crossed for another 3 weeks, but we should be okay. RSV is on the right side in the other green bars. This is green for good and go. And you can see that RSV is declining a little bit. Interestingly, like flu, the RSV season was actually a little early this year and seems to be going down faster. And so this is the good news. Next slide. COVID news is perhaps not quite so good. So on the left, you see the wastewater signal posted yesterday. It's not going away. It's really irritating. And on the right-hand side, you see updated COVID hospitalizations and COVID deaths. And they're not going up, which is good news, but they're also just not going down very quickly. And our current rate of COVID deaths, I need to remind you, means that if we keep going, that's 2.5 times more deaths due to COVID than to influenza in a regular influenza season. That's still a lot of serious disease and death due to COVID. And so we get back to people haven't had a bivalent vaccine. This is still a really good time to have it, even though everything feels like it's getting better because all those other viruses are gone, okay? COVID is still there. It's still dangerous. Now, a piece of the reason why this bump is happening, next slide, is, as I think probably everybody knows on this call, the XBB.1.5. So the purple upswing in proportion of cases on this slide is the modeling from Public Health Ontario of what's going to happen to XBB.1.5, taking over from BQ1.1 and maybe fueling the increase in cases. I think we should also be a little bit anxious, right? The other thing that may be fueling the increase in cases, or at least the non-decline, is waning immunity from our vaccine doses. Most of us got bivalent boosters 4 or 5 months ago, and in our oldest and frailest patient, that may be waning, and we just need to keep our really alert to the fact that we're not necessarily out of COVID yet. Next slide. Okay, so where are we now? Very clearly the worst of the viral respiratory season is behind us. That's really nice. It's going to go on for another couple of months, as viral respiratory seasons do, but nothing, I think, bad is going to happen now. The COVID burden is definitely going to continue to get better, right? We just keep, more people get vaccinated, more people get infected, population level immunity rises, things get better. This is good. Two things we don't know about what's going to happen to COVID. Okay, the first thing is, when is the severity of COVID going to stop getting better? Okay, every time somebody gets an infection or a dose of vaccine, severity of COVID goes down a little bit, but eventually it's going to plateau. And it might choose to plateau at seasonal coronavirus rates, which would be great, okay? If it's going to plateau there, that's probably going to take a couple of years, okay? So it's going to be a while to get there. It might plateau at influenza. It might plateau at something worse than influenza with our current vaccines, and then we're going to be dependent on new vaccines coming that do better, and we just don't know where it's going to hit. And the second question is, what's the seasonal pattern of COVID-19 going to look like? And let me just show you that on the next slide, that every virus has its own seasonal pattern, okay? All the viruses we have now, all the respiratory viruses we have now, have a winter pattern in North America and in southern temperate climates as well. But they're all different, okay? So on the top left, respiratory virus goes up in October and it stays up, and it comes down the other side, usually in March. You know, human parainfluenza viruses and enterorhinoviruses have different patterns. Enterorhinoviruses are what drive September and October illness when kids go back to school, and then there's a second low peak. Para is kind of reversed, where there's a low peak in the fall and a bigger peak in the spring. So everything has their own pattern, and COVID can do what it likes. We don't even know with confidence that COVID is going to be seasonal. Okay, it feels like it ought to be because all other respiratory viruses are, but it's going to do what it likes. And we're just going to have to wait and see. So again, this is about just kind of not letting our guard down, particularly for older and frailer patients, about how much damage COVID is still doing, and trying to make sure that we're protecting them, even as we kind of celebrate things getting better as we go on. Next slide. Okay. So I just told you that everybody needs their bivalent booster, and suddenly in the last 3 weeks, right? This is what happens when you get new vaccines, right? It's just like influenza, where you have to wait every influenza season until sometime in January to get the estimates of vaccine efficacy for this year. Our Canadian estimates from Danuta Skowronski's group just got published in Eurosurveillance for flu yesterday, I think. Okay, 50% good protection this year from flu vaccine, although it's a bit late to find out, as it turns out. But suddenly there's all this evidence on bivalent boosters. So here's the quick run through of the evidence. Left-hand side of the slide you saw already from Gerald Evans at the Last Community of Practice, observational data from Israel suggesting that bivalent boosters were associated in older adults with an 81% reduction in hospitalization. On the right-hand side, bivalent booster protection against hospitalization from the Ivy network of hospitals in the United States. No matter how long ago you had your second dose of vaccine, about a 60% additional protection relative to your previous 2 or 3 doses of vaccine in reducing hospitalization. Next slide. Okay, here's on number 3, the US COVID a vaccine tracker that you can see where persistently through the fall, it ends currently at week 47, which is the beginning of December, so a little bit early, but still about a 30% reduction in the death rate in people who'd had a bivalent booster compared to people who hadn't had a bivalent booster. On the right-hand side, another of the systems in the United States, what's called the Community Access to Testing Program, which looks at outpatient protection against disease, again, of 40 to 50% reduction. This is now not in hospitalization, but in symptomatic infection in people who've had a bivalent booster. Next slide. So slide 5, study of COVID-19 in residents of nursing homes by vaccination status. Nursing home residents, remember, are both more highly vaccinated and more likely to have been sick. So there's going to be a slightly lower increase in protection from bivalent boosters. But again, over the last weeks of the season, this consistent approximately 30% reduction in lab-confirmed COVID-19 in residents of nursing homes. And that 30% reduction at an individual level, of course, translates to significantly fewer outbreaks and less general pain and isolation in long-term care homes. And finally, another study just came out in the New England Journal looking at bivalent versus primary vaccination associated with hospitalization or death due to COVID in North Carolina. Again, we're still on short intervals that you can look at, right? So 3 months after your bivalent booster, suggesting a 50 to 60% protection against either 2 or 3 boosters. So lots of evidence now that you get a really significant increase in protection against currently circulating strains with bivalent boosters. Next slide. Okay, so now one of the things that a lot of people have been discussing for the last week or 10 days is the stroke signal in the United States vaccine safety data link. And I just put this slide up because if you just take a moment to admire how people design vaccine safety surveillance networks, this is a really cool approach to thinking about vaccine safety. What vaccine safety data link is now doing is they're using a combination of self and similar adult controlled estimates. So they look at people in day 0 to 21 after they get a booster. They look at what happens to them and they compare that both to what happens to them between day 21 and day 44. And they look at how somebody compares when they're day 0 to 21 to a similar patient, age, disease, site matched patient who is out between day 22 and day 42 at the same point in time. So you control for if there's other viral infections or other exposures that are going on at the same time. Just a really good additional way to try to make sure that you're not missing anything when you're looking for vaccine safety signals. Next slide. And in the last couple of months, what vaccine safety data link has seen is an apparent increase in strokes in people who got the Pfizer bivalent booster. Okay. Now, when you look at this, you see the signal, you know, the rate ratio was 1.47 and the one-sided p-value is 0.005. And all of us look at 0.005 and say, ooh, that's big. Okay. But remember, that's a one-sided p-value. The systems are designed to detect signals, okay? They're designed to detect if something's going on, that you get it really early and you investigate it and you find out whether it's real or not. But a one-sided p-value of 0.005 is a two-sided p-value, which is what you should be using in your head for actually thinking about risk of 0.01. And there are hundreds of comparisons that we're making in the vaccine safety data link, looking at a very long list of potential other outcomes. So really, this is despite that 0.005, this is okay, this is interesting, but it's not oh my heavens, something's really going on here. Okay, so people are exploring it. So far, I can only tell you that it looks consistent over time in the VSD data. It seems to be mostly occurring in people who got concomitant high-dose flu vaccine and bivalent boosters. So at least we can stop worrying about it in the short term because nobody's getting high-dose flu vaccine anymore this season. And it has not been seen in anybody else's surveillance system. So it's that last piece that's really reassuring, right? When you remember when we first saw VIT with AstraZeneca vaccines, within a week, everybody else's system kicked in and it was like, oh my heavens, yes, okay, something is going on. So the fact that you take it, you see a signal in one vaccine surveillance system and you then look everywhere else, it's when you see it everywhere else that you start worrying about it. So it's actually a really good illustration of vaccine safety surveillance systems are working, but it's almost certainly not something we need to worry about. We'll still watch over the next month or so just to make sure that it doesn't turn up anywhere else. And that's the end of my slides. Thank you.
Thanks so much, Allison. We're going to turn it over to Farin, and then we're going to take questions. But I just wanted to acknowledge that there were some messages that some people were having difficulty seeing the bottom of the slides. However, it seems that others were having no difficulty. So if you're having difficulty, maybe try a different device. I'm not sure because it seems like it might be related to the attendee setup. But I will also look on our end if there's anything we need to do differently. Of course, if you can't see the whole slide, they're going to be posted afterwards. And so you can always download them and view them then. All right, so over to you, Farin.
Thank you so much. And thanks so much, Alison. Always very informative to hear you. And I know even in Canada, the safety signal has been looked at and nothing detected here so far. So yeah, very reassuring. Okay, so I have been asked to speak about what is the COVID vaccine program in Ontario. So just sort of clarifying what is the current state, because I know there's lots and lots of questions, particularly around things like the intervals and all that, and about a second bivalent booster dose. And then I'll also talk about what is to come as far as we can tell anyways. But like Alison pointed out, there's still a lot of things evolving when it comes to COVID. So really tricky to make some of those predictions and then, develop a provincial program in response. So I just wanted to outline a really important point, which is the goal of the actual COVID-19 vaccine program. And it really is to reduce severity of illness. So not to prevent, symptomatic COVID infection, but to prevent people from getting very sick, ending up in hospital, or having more severe outcomes. And I think that's something we're trying centrally anyways to communicate more and more to the public. So there isn't that perception of, vaccine efficacy as it relates just to preventing symptomatic disease, but more so that real burden of disease and having people end up in hospital. Okay, so in terms of what people are actually eligible for versus recommended to get, this table is based on the NACI guidance, the most up-to-date NACI guidance, and they did just come out with a statement at the end of last week, I think it was now, which is publicly available on their website and reiterating some of these points. So this is just the can get is, what you're actually eligible for, and the should get is recommended as per NACI. So anyone 6 months to less than 5 years is eligible for a primary series, and the number of doses obviously varies if you're immunocompetent versus immunocompromised. And anyone over 5 years, so 5 years and older, is also eligible for a booster dose, so primary series plus a booster dose. In terms of what's actually recommended by NACI, they have said, so you'll see in their statements, they'll have wording like recommended should get, or recommended that they're, may get or eligible to receive. But the should get, or the recommendation, is for anyone over 5 or 5 and older, I should say, to receive a primary series. And then when it comes to that bivalent booster dose this respiratory season, in Ontario, we're roughly defining that as September 1st onwards. NACI has outlined that anyone over 65 and above is at high risk, and anyone 5 to 64 at increased risk of severe illness. So immunocompromised, pregnancy is a risk factor, comorbid conditions, respiratory heart disease, and other chronic diseases as well. And so that's the recommendation for the bivalent booster dose this fall, winter, or respiratory season, as we're calling it. Previously, and I just put that in italics there at the bottom, they have mentioned that anyone over 18 or 12 to 17 that's high risk should have, prior to this, at least received 1 booster dose. But just really focusing on that fall booster dose. Next slide, please. I just wanted to highlight some of the uptake that we're seeing in Ontario. So this is coverage for anyone age 5 and over as to who's received their booster dose this respiratory season. Overall, and I don't think we have this number on the slide, but overall, the coverage rate in Ontario is at about 20%. That's the most recent data. And you can see it really varies by age group. So people over 70 have a higher coverage rate. It's nearing closer to 58%. So still room for improvement, because we do know that age remains one of the a very important risk factor in terms of risk. And then you can see it just sort of declines by age group. So 50 to 69-year-olds, closer to 30%. So we're still really focusing on people getting that 1 bivalent booster dose this respiratory season. And that's how it's being framed in terms of communications right now. It's just that hopefully simpler message of get your bivalent booster dose, which everyone 5 and over is eligible for. Next slide, please. Thank you so much. Okay, so I know lots and lots of questions around booster dose intervals. So, and what we're talking about with interval is assuming you've completed your primary series. This is your interval from your next dose, or since your last dose to your next dose, and confirmed COVID infection. So we say confirmed COVID infection because obviously a lot of people are symptomatic, there's not a lot of testing happening, and people may not know. So if they don't know, then that's fine. They would just follow the interval from their last dose and ignore the symptomatic part. But if they've had a test positive COVID infection, then that's the confirmed part, which we're really trying to emphasize, so people aren't sort of assuming whether they've had it or not, and we're erring on the side of getting the vaccine. So optimal interval is 6 months, and NACI has said that in their past couple of statements. There is a stronger, more durable immune response the longer you wait between doses. There is a minimal interval still of 3 months in Ontario, and that's most appropriate for people at high risk of severe disease. And that's been emphasized. I think what probably has resulted in some confusion is that 3 month interval was really intended by NACI to be a one-time thing to catch people up in advance of that fall 2022, when we're expecting a more resurgence of cases and a wave to happen. So that has sort of stuck, and that's being actively looked at right now in Ontario. But scientifically, optimal is 6 months. 3 months people are still able to book in for, but that's most appropriate for people at high risk of severe disease. And then all that's going to be revisited and re-looked at in the coming months. Okay, next slide, please. And now this is a big question that we're seeing as well. So if somebody has already had a booster, or bivalent booster dose this respiratory season, the question is, what do they do now? Can they get another one at 3 months, at 6 months? What's the advice and recommendation? So this is where there's a bit of divergence between NACI and the provincial policy, and provincial policy is currently under review as we look to 2023 and figure out whether there'll be a spring program, a fall program, what have you. So right now in Ontario, we've taken more of a lenient approach, and people are technically eligible to book in at another 3 month interval. Again, that 3 month interval is most appropriate for people at high risk, and still trying to emphasize that a more optimal interval is closer to 6 months. But that being said, people might be in unique circumstances. Maybe they're quite immunocompromised. They have other factors they need to be aware of. Maybe they're, on the advice of a provider, they're very keen to get it. They are actually able to book on the provincial booking system at a 3 month interval to get a second booster. Now, this is not that many people, like you've seen, has actually taken up the first fall booster. So we're still like hovering around 50-60% even in that oldest age group. So the focus remains people getting that first booster, bivalent booster this respiratory season. But there is a minority of people who are starting to come in for a second booster at the sort of 3 month interval. So that is, able to happen in Ontario. And again, it's more of that sort of opt-in. It's not a broad population recommendation to have another dose. That advice is coming, and we will be, that's actively being looked at right now, and hopefully something announced closer to a month or 6 weeks from now, I would say. Okay, next slide, please. And what will the future be in Ontario? Okay, so you would have seen from the NACI statement, there's still not a lot known. Like Alison said too, the seasonality is still not known. We seem to be in a bit of a steady state with Omicron, less peaks and valleys than we were seeing before. And I should say this slide is all based on the fact that we don't have some radically new variant that's very severe and kind of a game changer variant. This is based on the assumption that we're not going to go in that direction yet, and so everything could change if that does happen. So yeah, really the future state is unknown. I think we're taking it kind of season by season and year by year. Right now, a few jurisdictions have announced a high risk spring program. So the UK looking at this, Quebec just announced and put out their statement yesterday. And they're actually doing something interesting where if you've never been infected with COVID, you're recommended to get another booster 6 months after, and that's just because of some emerging evidence on hybrid immunity and that having a sort of better duration of protection. I think layering in another nuance as to whether you've been infected or not when many people aren't testing might be a challenging thing to implement here in Ontario. But anyways, what we're looking at now and having active debates on is whether there will be a high-risk spring program. I think that's a possibility. It just, the question is obviously for who, and defining those high-risk groups. And then of course a fall program I think is a possibility too, with a slightly broader group, because at that point most people will be about 12 months out from their last dose, assuming they got a dose when it opened up at the end of September of 2022. I think in terms of the interval, again, the focus is more and more on the 6-month interval for now as a minimum. And so I do think eventually we will in Ontario as well move away from the 3-month minimum, just recognizing that was really intended to be more of that one time. I think that this kind of planning scenarios that are playing out is, you know, maybe something like once a year for the general population, possibly twice a year for high risk. And I think that will still look different year to year. So that might be the case, let's say for 2023, but 2024 might be different as well as we learn more. And I don't think it's going to be likely that people will need a dose, you know, more than once a year. I think that's not super likely. This is just, I should say, my own opinion. And based on what we're seeing with other jurisdictions and the evidence. So lots, I guess, to be seen, but that's kind of what we're thinking right now. And I think hopefully we'll see some more information in the coming month or two around a potential spring high risk and really defining that further. Next slide. Yeah, and then just a couple of points to highlight from some previous sessions. So I know there's been questions around co-administration. So NACI has changed its recommendation so that anyone 6 months of age and older can have a COVID vaccine co-administered with another. So this could be at the same time or any time before or after. So that's no longer, I think it used to be 5 years of age and older, but anyway, it's 6 months of age and older. And then I know there were lots of questions around the Paxlovid pre-prescribing, and the clarity on this is yes, so a physician and nurse practitioner, like with any other medication, can write a prescription in advance for Paxlovid. So this might be appropriate if someone's very high risk, recognizing that from time of symptom onset, Paxlovid is most effective the sooner you take it and within that first 5 days. So people are kind of opting to do this, and that's very appropriate. When the pharmacist is actually dispensing, then they do need a positive test. So you can sort of hold it at the pharmacy, do that risk assessment up first, and that's encouraged, and leave a script with the pharmacy. But to actually get the dispensed medication, they would need a positive test, and that could be an at-home rapid test as well. That's not an issue. And so there is communication going out as well to the field, because we heard that that's not always happening. So we're working on that as well, just to clarify for everybody. And then I saw a couple questions on Mpox, so formerly known as monkeypox. The outbreak was declared over December 10th, but you'll probably have seen that there have been a few cases since that time. So Toronto Public Health just put out a media release about 4 confirmed cases that they've seen recently. And we're really trying to promote second doses of vaccine. So probably about 20% of people that have gotten a first dose of vaccine have gotten a second dose. And you know that number obviously could be optimized a lot more, and you really do need the 2 doses 28 days apart to have optimal protection for Mpox. And next slide. So just a couple of additional points on this in terms of where people can go for more information. So if you're looking for information about eligibility, the Gay Men's Sexual Health Alliance has a very good website, really accessible language, and talks about clinics across Ontario. So it's a very good resource, and the public health units in Ontario often partner with them to get their clinics promoted that way too. Typically, eligible patients are people that are part of the GBMSM community, so gay, bisexual, men who have sex with men, and also people who might be engaged in sex work. That's another eligible group. So yes, that's a good thing to promote. If you have eligible patients, make sure to tell them about the 2-dose series and getting a second dose. Next slide. And this is just a quick reminder of where people can go to get vaccinated for COVID-19. So there is a provincial portal, provincial vaccine contact center that if people prefer to phone in, and we are still active on the GoVax bus, so doing a bunch of mobile clinics at various high-risk locations. And the rest are probably familiar with. So I'll leave it at that and turn it back over to Tira.
Thanks so much, Varian. And I also just wanted to, as we're closing out some questions that came up on our last session, just remind you of the study we talked about last session. So if you have a patient who's COVID positive, considering referring them to Can Treat COVID for treatment, basically adults with a positive COVID test 50 and over, or 18 to 49 with one or more chronic conditions are eligible. And, it's an easy phone number to call, and the pharmacist dispenses the meds by mail to get right to your patients and can give them the counseling over the phone that's appropriate. Understood that this is a randomized trial, and we talked last time about why it's still appropriate for folks to have this, why we need to have a randomized trial, because of the state of the evidence, and that, as family doctors, will be contributing to the science that we'll hopefully be using in the coming weeks. So thanks, Allison and Farin. I just wanted to highlight a few things that have come up. So we can just end slides for now while we go to the Q&A. I think just one thing that struck me, Farin, as you were talking about, the booster uptake is that, still, when we look at those 70 and over, there's still, more than 40% of those 70 and over haven't had a bivalent booster this respiratory season. More than 70% of those 50 and over haven't had a bivalent booster. So those, as you said, COVID is really related to age in terms of the risk of severity. And so we need to do our work as family doctors to try and remind our patients, especially those who are older, to get that bivalent booster. I do wanted to just also follow up on your clarifying question around Paxlovid, Farin, because you mentioned that physicians can write a Paxlovid prescription and have it available at the pharmacy for when a patient has a positive test. People are asking if there is written confirmation about that, so that they can show the writing to the pharmacist. And if you do have a written, if you could put that, if you have somewhere they can go on a website, if you can put that in the chat, that would be great. So then we can, so I heard you nodding. Did you want to speak to that, Farin?
Sure, yeah, thanks. Yes, that is coming out. So we're working on a document for that, and that's like imminently being updated. So we'll share that out for sure. And then you'll have a resource to point to. And again, communication with the field. So in upcoming meetings and things with the pharmacy sector, we're reiterating that as well. So for sure.
Great. So just going to some questions. I think that the first couple questions might be for you, Allison. So the first one is, could you comment on the Cochrane study from October 2022 showing that masks, including N95s, were not helpful in preventing COVID or influenza-like illness in the community, and probably not in healthcare settings as well? Allison, you're on mute still, sorry, for some reason.
Yeah. Measuring effectiveness of preventive measures is an extraordinarily difficult thing to do. And the Cochrane rightfully has very high standards for what they consider evidence. So, we're at, I think, a very difficult intersection of trying to understand what happened. At a population level, what we've just had is a demonstration, an unequivocal demonstration, that if you reduce your contacts, put a mask on, and maintain physical distance from people, that you stop the spread of viruses and bacteria, right? There have been dramatic decreases in pneumococcal disease and group A strep and influenza, where we thought there was no way you could prevent transmission, okay? So it turns out you can do that. Now comes the really hard question. Okay, what combination of reducing your contacts, maintaining your physical distance, and putting a mask on actually makes a difference? And that is a much more difficult question, because all during this, we bundled those pieces and we don't have really good measures for any one of them. So I think the Cochrane is correct in their conclusions at the level of evidence they require. To me, however, I think there is good evidence that masking has an impact. I just don't know, how to translate that to, specific circumstances in which it has, or what's going on. And let me give you I think the best evidence to me now about masking and respiratory viruses is the season we've had in long-term care homes, okay? So my measure of season with long-term care homes for respiratory viral seasons is how many pages the long-term care outbreak list from Toronto Public Health is, okay? When we're not in influenza season, it's no more than 1 page. When we are at peak influenza season in an average year, it's 8 or 9 pages, okay? If you take COVID outbreaks this year, we haven't been past page 1.5. 1.5 pages. That is a dramatic reduction in respiratory viral and influenza outbreaks in long-term care homes. And we're fairly close to back to normal in long-term care homes, except for the masking. So I really think that masking has a fairly substantial impact in that very specific setting of close congregate living, okay, right? So that's not, what happens on the street or the grocery store or other things. So the challenge now is figuring out how to test those hypotheses and how to get us decent answers about what masking or social distancing, or what we keep calling social distancing, but it's actually physical distancing, right? Actually means and where we might use them. So and let me tell you, people who care about influenza have been working for years to try to get answers completely unsuccessfully, okay? So don't hold your breath on how fast it's going to come.
Thanks, Allison. So the next one is either for you or Farian. Someone asked, Farian, I think you just typed the answer to it actually, maybe, so maybe you could just speak to it, but someone asked, I'm trying to find the question now that you typed to, is the Moderna bivalent better than the Pfizer bivalent since XBB is evolved from BA2?
Yeah, it's a good question. So no, everything that we're seeing in terms of vaccine effectiveness data is showing pretty good equivalency with all the bivalent products, whether it's a BA1, whether it's a BA4 or 5, and NACI as well doesn't have a preferential recommendation for one bivalent product over the other. I think there's, some degrees of cross protection. There's different sort of Omicron variants coming and going. Some are recombinants, et cetera. So no, they're all pretty equivalent, and so could use any of them, and they're all pretty available.
Great. So I think someone also asked a similar question around, how effective the bivalent is for XBB, XBB1, and I think Allison, you wrote that almost certainly it is effective, but not perfect. I don't know if you wanted to expand on that. You're on mute again.
3 for 3, yes. So what we're seeing now with the Omicron variants is this gradual, departure. What we see with flu, which is kind of nice and reassuring, okay? It feels like it's COVID kind of settling in as opposed to some new weird variant. So each step in the process tends to move the virus a little bit further away from the antigenic characterization of the vaccine. So the vaccines will probably not be quite as effective against XBB.1.5, but the difference is not going to be dramatic. So we're not going to go from 60%, which is what we're seeing with BQ1.1 and XBB, down to something that is like 30%. It'll slip a bit, but probably not very much.
Thanks. So there is a question of clarification, Allison, about your comments related to the Pfizer bivalent and the stroke signal. And somebody asked, did you say that the risk is higher if you had the high dose flu shot at the same time? So just if you could clarify.
Yeah. So once you see a signal, you go looking for what else might be going on? Is there something specific about it? So they went and looked, for instance, on whether it was occurring in a particular subpopulation or whether it was occurring in a particular location of vaccine safety surveillance, or whether there was something else about the patients that was different. And in that detailed analysis they did, there did seem to be it did seem to be more common in people who got the high-dose flu vaccine and the Pfizer vaccine at the same time, which is okay, but it didn't happen in people who got the Moderna vaccine and the flu vaccine at the same time, which is like Moderna and Pfizer are very similar vaccines, right? So I'm sorry if it led people down the direction of, that might have been something. I think the answer is it's still a signal that has no validation. And while there may be some validation, it was somewhat reassuring to me that if there is something, then maybe it's something that was two vaccines together as opposed to one vaccine, which to me takes a little bit of the pressure off with worrying about it if you're just giving bivalent boosters now. But honestly, this is a signal without validation. And in vaccine safety surveillance systems, a signal with no validation is not something you worry about.
Thanks so much, Alison. So, I know there are a lot more questions, and we'll certainly try and get to many orally, but in the meantime, thanks to Alison and Farin, who's been answering through typing many of the questions, and they're going to continue to answer by typing many of the questions while we move on to our next speaker. So I wonder, Leanne, if you could bring up Mohammed's slides, and then following Mohammed's talk, we'll take some questions for him, as well as go back to some of the COVID questions. So Mohammed, I know we're going to switch gears a little bit here, because I know we wanted to make some time today to also talk not just about the updates to COVID and COVID vaccines, but providing people with practical resources to address the very real kind of clinical burnout that's occurring or that has been really present for the last several months. And we know that technology can contribute to burnout, but can hopefully also reduce it. So over to you to give us some practical tips on how we can better manage in the clinic.
Yeah, thanks very much, Tara. And I think you said it, like we want to look at this holistically. We know technology is not a silver bullet, but we also know that we need to do something about it very soon, because clinicians are leaving the profession. And so there is a big challenge. And hopefully you can take some things from what I talk about today, and they will benefit you in your practice in the near term. So we'll move to the next slide. So I probably don't need to spend too much time on this, because everyone is feeling this. As primary care clinicians, a lot of our time is spent on administrative work, doing forms, documenting, double documenting. And so, it is a big challenge. The college has looked at this and really recommended that we need to hit this head on and decrease the amount of administrative time, do things similar to what the UK has done with maximizing that administrative time to 10% of our week. Nova Scotia has moved forward with setting a target of reducing administrative burden by 10%. And so that's certainly a start. And we know that this leads to not only more hours for clinicians, but less time for us to look after our patients. And so, we're able to see less patients. We're able to spend less time with patients. Our staff is able to spend less time because we have this administrative work. And the Canadian Federation of Independent Business put out a really good report on this, and what the benefit would be if we actually started to reduce this administrative burden. We'll move to the next slide. And so what do we do to help? And I think this is really important for us to tackle and look at. We'll move to the next slide. And we need to look at in a way that really works with clinicians. We often have things done to us, like technology solutions will be put forward to us, and we'll have to use them. And as Tara said, that leads to increased burnout. And so what we want to do is we want to make sure we understand, like, what is the actual problem that we're facing, and then look at how do we iterate on a solution. And I will say, none of these things that I'm going to talk about today is going to be perfect. It's something that might be a start for some of you. Others of you, you might not want anything to do with some of these things, and that's perfectly fine. Like, it really is about, here's a bunch of tools in the toolbox. Are there some that would help you? We have this clinician experience lab, the healthcare experience and advancement lab, that really works with clinicians across the province to look at what are the problems and come up with solutions. Currently, we're looking at things like inbox management, unfiltered messages, partial results, duplicate messages. What can we do to sort out that problem? We've also heard about forms and having challenges with all these different forms being updated, not knowing about it. How many clinicians and clinics across the province are actually taking the same form and digitizing it? And so can we do something in terms of supporting common sharing of forms and automatic updates in EMR? So those are two things we're looking at. If you're interested in helping to define that, you can go to that website at the bottom and just chime in, give us ideas, and participate if you like. We'll move to the next slide. And so what are the ways to help with this? And again, we're going to look at a number of different things. We use virtual assistants in our lives. And so, on the prompting of clinicians, we've really looked at how do we support them with the family of virtual assistants. So these are really software programs that do the repetitive, mundane tasks that we shouldn't be doing, that our staff shouldn't be doing. We've been able to test out these virtual assistants in over 60 clinics and with over 400 physicians, nurse practitioners in this province. And we've seen that they've saved a lot of time, 20% of clinic and staff time. They're 6 times faster than manual labor. They don't complain. They don't need to go to the bathroom. And so there are advantages to using these virtual assistants. In one clinic of 10 physicians, for example, one of the virtual assistants saved 87 hours of time. We have a family of virtual assistants. We have Bernie, who burns out so clinicians don't have to, and does things like document things in the EMR and follows up track test results. We have Cody, that codes and standardizes data in the electronic medical record and identifies patients that would be at risk, and then hands those patients off to Ontario health teams. We have Sharon, that shares information between information systems, so really takes information from one system and puts into the EMR, so it's right in front of you. You're not going to another system. And then we have a new arrival working with East Toronto Health Partners, really looking at population health. So Poppy, looking at preventative care, reaching out to patients automatically for cancer screening, and particularly those in vulnerable neighborhoods. So we're quite excited about Poppy and what Poppy can do for us. And then finally, in terms of virtual assistants, we're looking at auto scribing or digital scribing, where you have technology that will come up with a beautiful clinic note as soon as you're done talking with the patient. So you've been talking to the patient, and then there's a note that's ready. You can edit it if you want, but you essentially don't have to type anything. So we're hoping that to move forward in those things. We do have it for TELUS. We have done work on Oscar, and we are working on Akiro that's coming slower. The intent is to have all of these available for those 3 EMRs as well as every EMR. So essentially have a virtual assistant for every clinician in the province. We'll move to the next slide. And so other things to think about, online appointment booking. So good research on this. This is a systematic review, really looking at how it can help you in your clinic. So things like reducing labor costs, things like decreasing no-show rates, and that's sort of been consistently shown. And so there are advantages to moving forward in this. There are also things that are challenges, things like cost of this. Clinicians do feel they might lose control. I think you need really good support to get onboarded to this, but there are ways to put in a place where you don't lose control. But I think we have to address all of those things and make clinicians comfortable as we move forward. We'll move to the next slide. In terms of accessing services, so big challenge is how do you get a patient into a specialist or other service. Lots of good talk about central intakes and how do we make it easier to organize services in the province. There's a program, the Ontario e-Services program, looking at digitizing both the referral workflow as well as the workflow, asking about advice. And I think, there's support to get it into your clinics. I know that, it seems like it might be more work, but it can be more efficient. And there's a team there to sort of help you to do that. And we are moving forward. We're looking at e-ordering. So we're already doing it for MRI CTs, but looking at it for labs so you can automatically order that lab test electronically. We'll move to the next slide. And then finally, if you think about sort of all the evidence that we've sort of seen today and the evidence that's out there, is there an easy way to take that evidence and put it right at the front where you're talking to a patient, right at your clinic? And so this is a new program called Evidence to Practice Ontario. We're working in partnership with the Centre for Effective Practice and North York General to really take the evidence and synthesize it and put it both into primary care and acute care. So there's a common view of the patient, and that information is always up to date. It guides you through what you need for the patient. It's modular because patients don't present with only one condition, they present with multiple conditions, so you can put those together. So really an effort to make it easy for you to have the evidence and do things like manage heart failure, depression, anxiety, diabetes in a simple way. We'll move to the next slide. This just shows there's a heart failure tool that's available in TELUS EMRs. It is coming for Oscar and Accuro and other EMRs as interest is sort of raised. And this really is about helping with diagnosing heart failure, understanding what the best practice medication management is, and then where are the supports in the community to help that patient. We'll move to the next slide, which is the last one. And so if you want more information, if you want to complain about things, absolutely, like just email us, and we're happy to sort of address those. As I've said, it's a journey really to look at how do we improve your practice and decrease admin burden. We're certainly not where we need to be yet, but we hope to sort of go on that journey, both from a technology perspective and also from a process perspective. So really happy to sort of get your feedback. Appreciate the opportunity to talk to you. So I'll hand it back to Tara, and I know there's a few questions, and I'll endeavor to sort of answer them in the chat.
Thanks so much, Mohammed. You've spurred lots of chatter, and maybe I'll just summarize some of the comments. I think some people reflecting on how the administrative burden has really grown. When they started, maybe it was 20% of the time, and now it might be 50% of the time. People are, bemoaning the many different referral forms that we have to do, that different centers make custom, so that we have to fill out and figure out different forms and have them kind of integrated into our EMR. Some people, like Alan Grill, have made a workaround so that their staff know how to, navigate the Hospital for Sick Kids portal, for example, which I know is it's a big pain. And then there's many people bemoaning how we have to do lots of forms and letters, sign off on physio letters and sick notes, and how, a lot of these, what we're feeling as burnout, so many of that is related to external factors. And then there are many comments about HRM and duplicative reports, and people feeling really overburdened by that. So just wanted to acknowledge a lot of that chat. And certainly we can talk about some of that, Mohammed, but I also did want to put forward to you some of the questions that practically speaking people have put forward. So I think one of the top ones is, when you look at your virtual bots, can you just restate which EMRs they're available for, and how can people access them, and what cost is involved?
Yeah, so there is no cost. We are not funded to spread all of them, so we can let you know sort of which ones are funded. Certainly the Bernie bot to help with COVID immunizations, we're doing that for anyone who's interested in terms of taking COVID immunizations from the chart and putting it in the immunization section. The bot, so all of them work for TELUS. The Cody bot works for Oscar, and we're working on the Bernie one for Oscar. And then Accuro is a bit slower, so we're working on that for all the bots. We need to move forward to make sure that the bots are available for every EMR, for every clinician in the province. So that's our aim. There is no cost, and we don't intend to do that. We're just looking for system funding actually to support that. So that's.
And so if people are interested, should they just contact you, Mohammed? Maybe at the end, we'll make sure you put your email in the chat. And then that way you might get a flood of people who are interested. And you can also maybe provide us with a one-pager that we can go take out that tells people what they could potentially be eligible for based on their EMR, because there's certainly lots of interest there. I think people are kind of a little bit describing how maybe they're a little bit sad that the virtual bots, are they really going to reach the people who are most vulnerable? I know you mentioned actually your partnership with East Toronto and the interest there in supporting the most vulnerable. So I don't know if you wanted to comment on that.
Yeah, so it really is like, how do you identify the patients that need the most help? And so the bots can help identify those. So we're actually using things like neighborhood data to identify patients who are in more vulnerable neighborhoods and have other conditions that may need to be screened. And so part of the opportunity here is to identify patients who we often may not think about. And so once you identify them, then the bot can do something like tell a team member, if you have a team, right? And we're getting more teams or an Ontario Health Team individual to follow up with the patient. The bots can text the patient. They can do robocalls. We haven't done that yet, but they can sort of connect with the patient in different ways. I think it's part of a bigger approach, though, really to look at how do we support the vulnerable patients in our communities. What the bots can do is they can just highlight who needs help in a more easy way. And they work on the clinician end mostly to do that. So we recognize that there are challenges with digital technology in general in terms of access to that, but something like a text is a simple way to connect with the patient and know that they may be due for a test, or they should really connect back with the clinic to chat about some things.
So again, lots of people, putting in their thoughts into the chat. Just wanted to echo Kim Moran's comment that, the OCFP has been consulting with hundreds and thousands of physicians across the province. And, this administrative burden is like what they're hearing over and over, and one of the biggest pain points, and they're really committed to addressing this. I think some people are feeling sad that they're on Accuro or PNP or something that you're not going to be able to support. I think there's also comments that they wish you had some stuff for long-term care where EMRs seem to be a bit behind. So I wonder, Mohammed, so I know this wasn't in your talk, but I wondered if you wanted to speak to the HRM issue, just because it did get a lot of play in the chat and it does drive people crazy.
Yeah, absolutely. So we are going to support the Accuro folks. So don't worry, we're gonna keep on pushing on that. We can have a support group too, and complain about things. That sometimes that does work. I think in terms of raising attention. In terms of HRM reports, there are groups sort of provincially looking at both from a sending facility perspective, like how to standardize the reports and how to make sure that you're getting the most appropriate things. And then also on the EMR end, in terms of what's coming in, I know lots of duplicate reports coming in. You're being fax reports and HRM, and you're getting updates, frequently with sort of unfinished reports. And so there's provincial work happening on that. I think people have been heard. It is taking some time. So I think it's really important for us to look at how do we accelerate that? How do we make sure that you're getting the right message, it's categorized in the right way, what the urgency of it is. And so, I think we need to just keep on pushing on that. There is work happening, so people can be rest assured in that. But I think it's important to ask those questions and to keep on pushing. And, it'd be great to hold some sessions, talk about what are the top 5 things that you need to fix. And then really just where's the accountability, and then make sure we're accountable to fix it, right? Because I think that's what this is about. People will leave the profession if we don't fix some of these things. And so we need to move forward very intentionally and do that.
Yeah, great point. I mean, I think some people are also saying, the EMR should just be able to filter all these duplicate reports. Why is it that we're needing to manually do that? And for sure, the sender can work on it, but the EMR could also filter it. So there's many ways of getting at the issue. Interesting, we've got some innovative colleagues on the line. Ian Pun talks about how he's been using ChatGPT to help him do faster insurance notes and other things. So maybe that's a topic for a future session. I also continue to get messages in the chat about specialists. And so maybe that's also a topic, specialist referrals and just referrals in general to centers. And so that might also be a future topic. I wonder, Mahale, if you wanted to speak to the work that you did in your community around HRM. I know that it was, when we were talking about it before, you mentioned how you were successful in actually reducing the duplication through some of the efforts.
Sure, I would say not quite yet successful, but a work in progress, and I feel hopeful about it. I think, so in my community in Cambridge, we've noticed that it was more the mislabeling. Some of the reports that are coming in are being mislabeled where, I don't remember exactly, but I think site consults are coming in as like lumbar spine x-rays. And it just means that we then have to take the additional step when we're placing that report in the chart to relabel it to ensure we can search accurately. So essentially, we're just keeping track of these common mislabels because they seem to be consistent. And I've now found the person I need to speak with at the hospital, and I'm going to send them my list of these are the reports that are frequently mislabeled. And I'm being told that they're able to make that change. So it's a small thing, but I think it's those like thorns in our side that if we can change them, they seem to make a bit of a difference in our workflow.
Thanks. So I'm just going back to the questions here, and there's some very specific questions actually about these separate websites that are that require certain referrals that have special websites where you need to do the referral. Sick kids again and again comes up as one of the most time-consuming, burdensome referral processes. I know myself, like I'm dissuaded from referring there a lot of the time because of that. And so Kara, one of our attendees asked, is there any way to advocate for us to change the system? And another attendee talks also about the Ontario Bariatric referral system where you have to have a separate username and password, and these change every 3 months. So, again, is there a way for us to advocate for that? So I don't know, Mohammed, if you have some responses, or Mahalay, if you wanted to speak to that.
Yeah. Happy to jump in. So we are talking to those organizations actively about connecting to the e-referral network so that you would launch it right from your EMR. It would pull all the documents automatically from your EMR. You'd already be signed in and you'd be able to refer. We've already integrated to the same hospital system that Sick Kids has, for example, it's Epic. And so we've done that with other hospitals. And so it actually is something that is straightforward, I would say, to do. So I think it really is, for folks to keep on sort of raising their voices, but what I'm happy to sort of take this away and then come back with, what we're doing on that and what the steps are, where we're at with those things. Same thing with Ontario Bariatric Network. So we have agreed with them to look at some integration of e-referral right into the Ontario Bariatric Network. It was delayed a little bit because some of the funding, we didn't get the funding from that particular initiative, but we're looking to try to push that forward. So there is some progress on those. And certainly we are looking at all hospital systems. So we have integration with Epic. We're working on Cerner and Meditech with the other two big hospital systems. And so those three systems, Epic's already integrated. The other two will be done within the next year. So I think things will improve in terms of that, but I acknowledge that it is a big, it is a big problem. Referrals in general, in terms of who to refer to, declined referrals, take a lot of time from our staff and ourselves.
Okay, so just to one more question for you, Mohammed, and then also just wanted to, before we go back to some COVID questions, but also wanted to mention some tips in the chat. So David Dane mentions that working with the senders is the best way to improve HRM delivery. So that is, just what Mahalay described their family practice or family health team doing where she is. And of course, it's easier when you only have a couple of hospitals that you're working with, and I think harder if you're getting it from multiple hospitals. But maybe I could ask you, Mohammed, about the dictation bot. So there were some questions about that. So is the dictation bot already available in TELUS, and kind of how does it work? Is it, are these type notes like older pre-printed notes consultants used to use, or are they kind of listening and then typing what you're saying? So can you expand on that a little bit?
Yeah, it's really neat. I've tried it out in just sort of mock sort of interviews with people, and yeah, it will be listening to you and the patient sort of interact, and then it will summarize that in a SOAP note that goes into your EMR. So it's in the format that you would, like natural text format that you would do. There are companies that do that, so we're just talking to them about how to sort of integrate that into the EMR. Some companies have sort of integrated with Oscar. They have some approaches with TELUS that they're working on. And unfortunately for Akiro, they're not there yet, but there are active conversations on that. So these are existing a lot in pilot phase right now. So they're testing this out. They're pretty good from what I've seen, and they're getting better really quickly, just like artificial intelligence is rapidly. So different jurisdictions use them sort of very regularly, and there are different platforms actually. Some of the virtual care platforms that are out there, the private companies are using them a lot. So I think they will come into mainstream. I think it is going to take a little bit of time though for people to get comfortable with using them. And for them to become easily accessible through EMRs.
Thank you. So just going to highlight a couple of things that people again are saying in the chat. So, and then Allison and Farin, just want to tee you up that I'm going to ask you a few questions next. But, in the chat right now, some people are talking about e-consult and how that's been a wonderful kind of game changer for them, made things a lot easier, how they really needed some good, though, IT support within their organization to kind of get that going, but maybe that's something we can feature in a future community of practice. I also personally wanted to give a shout out to online booking. Again, I have a very supportive practice that have, supported it to be implemented for a number of physicians, and I've been using it for a year now, and it's been very easy, and my patients love it. So definitely put a plug in for others to try that out. All right, so I'm going to go now back to some questions. I know Allison and Farin, you've been busy answering a lot of them. So if there are also some things that you've been answering again and again that you want to just highlight, please do. But I know that one of them that's sort of sitting up here relates is for you, Farin, is what would be and it's about masks and mandating masks. So I think there are people who have asked different kinds of questions on that. One is, do we need to still ask our patients to wear masks in the office? Many of them don't want to. Others are saying, well, what would be the risk of mandating masks in healthcare clinics and facilities? As a person with a high risk condition, it's, I have trouble accessing care, as well as working as the clinic doesn't, when people don't wear masks. So I wonder if you're able to answer that, Farin.
Yeah, sure. I think they're really good points. And obviously this has become somewhat of a polarized issue, which is not great. But I think, there is good evidence on a population level about the use of masks, especially high quality medical masks or N95s, in terms of reducing transmission and both being protective as source control, but also for contracting it yourself. So I think what the messaging has been anyways is that it's one of many things that people can use in addition to vaccination, other environmental controls, therapeutics and things like that. But the whole question of mandating it obviously has become more more in the political domain, I guess you could say. And I think right now there is no indoor mask mandate. And I know that was sort of a point of contention as well. And that's just balancing, at what points people might listen, and at what point in the pandemic do you go forward with a mandate? So not easy decisions. I think healthcare institutions on their own, though, and clinics can sort of, and other employers, I guess, can make their own decisions around requiring masks. So I think your own kind of clinic is able to have that policy, and same with hospitals. And I think many of the hospitals still do, as far as I know. Risks, I guess, are minimal, I would say, and I'm just speaking for my own opinion here, but yeah, I think the risks are minimal, and I think there are places where the indoor masking is much more emphasized. So like crowded environments, I think healthcare setting is another one where people tend to have that tendency a bit more.
I mean, I think the person is making a comment that they would like to have, that support of the ministry to have, mandated masks in healthcare settings. So I think that's the sort of the sense that I'm getting. And I understand that that's sort of a political piece that's sort of hard to probably comment on fully, but maybe I'll just move on to another question here just about the vaccine. So I guess, there've been some comments here, and I just wanted to echo some of the points you made earlier. So basically people are eligible for a bivalent booster after 3 months, but 6 months is the optimal interval. And so even if they've had one bivalent, they can have a second bivalent, and often that's an individual discussion. So there's lots of questions about that. And then there was some interesting discussion, Allison, that you responded to about, people, there's some comment about the Quebec Ministry of Health that, whether you really need a bivalent if you've already had COVID. And I wondered if you wanted to speak to some of what you wrote there, because I think there were some interesting tidbits for folks about immune protection following the condition.
Yeah, I think I haven't actually seen what Quebec is recommending. I've only heard about it because it just got posted, but there is good evidence that that hybrid immunity, okay, that having had vaccine and COVID gives you better protection than just having been vaccinated. Okay, it's one of those terrible things. It's like, I don't want you to have COVID, but if you've had COVID, that's actually really good in terms of going forward and protection. And if you look at the new data from Jeff Kwan and Sarah Buchan at ISIS, the protection against COVID, even hospitalization, is, if I remember the numbers right, somewhere between 70 and 80%, if you're up to date with vaccines, but it's like 95% if you're up to date with vaccines and have had COVID. So it's very clear that bivalent boosters and repeated bivalent boosters are of greater benefit to those older adults who have not yet had COVID, and a less benefit to people who've already had COVID. So Quebec has decided to start to differentiate that. I think NACI and some other provinces have felt that, the problem is, how do you know you've had COVID, right? So, there are people who've had asymptomatic COVID. There are people who've been symptomatic and maybe think they've had COVID, but they're not sure. There are both false positives and false negatives that happen with rapid tests. So I think most other jurisdictions have been reluctant to make a recommendation based on whether you've had COVID, just because of the uncertainties of knowing whether you've had COVID or not. So I think it's worth keeping in mind when you're talking to individual patients, because very clearly, if you haven't had COVID yet, and that's probably at least 30% of older adults have not yet had COVID, which is this is a congratulations, okay, we did well, we want that to happen, okay? But those people do need, are in more need of bivalent vaccines and boosters than those of us who are older and have had COVID. So I think it's an important distinction for us to start trying to keep in mind, while recognizing that it may not make sense at a population level to make recommendations based on whether or not you've had COVID.
So I know so thanks, Allison. I know we're running out of time, but I also know that actually our panelists have collectively answered 67 of your questions in the Q&A, and there's lots of great information. So some of the things we didn't get to talk about live, but there are answers there that we'll summarize in the FAQ relate to kids and teens. And I know, Allison, you said there's not a lot of data on the effectiveness around hospitalizations in that population because of low uptake. Farin, I think you made some really, nuanced points about, views on whether that immunization should be included in the school schedule or not. So I think I encourage people to read what you said there. So lots of really good information in the Q&A that we'll try and summarize. I'm going to just bring up our closing slides now. And maybe just as we're going to the closing, I don't know, Farin or Allison or Mohammed, if you guys have any last things that you wanted to talk about, or just flag for folks based on all of the questions that you've answered.
So if I can just come back to masks for a moment, I think, this whole discussion about taking masks off in healthcare, I think it's coming from everywhere. And my sense of the hospital community is that I think we're all hoping that maybe we can start talking about stepping down masks, but maybe not until April. So I think it's reasonable to kind of be encouraged about the fact that we're moving in that direction, and people will start talking about it. But I think most of us in hospitals are still thinking like, not yet. Okay, just like hold on for another couple of months. Let's make sure if we're going to have an XBB.1.5 wave, we get past it. But it's within reach. Okay, which is, I think, is why we're starting to have the discussion about whether we really need it.
Thank you. Bahrain or Mohammed, is there anything you wanted to say as we wrap up?
Yeah, I just saw a couple of questions around, what about things like polio, et cetera, and just wanted to say, obviously, other than COVID vaccines, immunization in general is a big focus. And so coverage obviously took a little bit of a hit during the pandemic. And I think there's been really, really good efforts to catch people up. So I, personally worry about things like measles, because even a small dip in coverage could have an impact, but obviously like monitoring that really carefully and doing a lot of preparedness activities at the province for that. But just wanted to say, I think there's been really good efforts by primary care and public health to catch people up. So just not to lose sight of all that.
Thanks, Bahrain. Mohammed?
Keep the feedback coming is really I think really great things in the chat in terms of challenges. And these are things that impact your day. They impact the way that you work. Information systems in general haven't been designed to help us. They've been designed for different purposes. And so we need to make it better, and we need to have a collective voice. So I'm sure my inbox will be full with different things. That's okay. We'll get you the help. And I think there's a lot of work happening with ourselves, with Ontario MD, Ontario Health, to really try to make it easier, although it might not feel that way, but we need to hear from the field. So please keep it coming, and we'll look to address each and everything that you've brought forward.
Thanks, Mohammed. Are you able to put your email into the chat? Because I know some people are requesting.
I did, yeah. I did earlier, but I will do again. Yeah, I will do that again.
And so we'll just bring up these last slides, and we wanted to just acknowledge the, it's been a hard time, and acknowledge the some success here, in that we've got a government announcement of some new interprofessional health teams. This is the first announcement of its kind in a really long time. As you know, we've had a pause on the growth of teams, and so this is really a win for our profession. Of course, there's lots of details still to be heard about what exactly this entails, where they'll be, what professionals, etc. But on the face of it is good news. And so I wonder, Mehaly, if you wanted to say a few words about that.
Yeah, just to touch on it briefly, I think we know there's a lot of work to be done in primary care, but I think this is a really important step in the right direction, and maybe a sign that our important role as family physicians and those of us who work in primary care is starting to really be understood and appreciated. But I hear you in terms of the admin burden. We will certainly continue to advocate. We hear from family physicians all the time that really is our #1 pain point. And we know it's really contributed to the crisis we're facing in terms of the shortage of family docs. So thank you for everything you do, and we will continue to advocate on your behalf.
Thanks so much. So just to the next slide, I just wanted to share with you some new data from our team. If you're interested, check out data.ourcare.ca and use it in your own advocacy efforts. It has some up-to-date information from a survey we did of 9,000 people in Canada, and their hopes, preferences, values related to primary care, what their experience is like. And of course, it does highlight that way too many people don't have a family doctor. So thanks to all of you for the continued work you do on that regard. We'll go to the next slide, and just to show, another plea and call out to say that if you want to join our our planning committee for these COP sessions, we would love that. We're always looking for new voices from different regions, different practice models, to add diversity to our planning team. And of course, if you don't have time for the planning team, but you have ideas, please do send us that as well. So if we go to the next slide, our next session is on February 24th. We're going to focus this session coming up on long COVID. We're, of course, going to send out an evaluation after the session. So if you have other topic ideas for future sessions, please do share them then. Of course, our slides, a copy of the recording, as well as the Q&A and the resource list will be posted to our website later today. The Q&A sometimes takes a bit longer, but the slides and recording will be there later today. And a big, big thank you to our incredible panelists who together answered so many of your questions and provided us with some of the latest up-to-date evidence, policy, and practical tools that can support your practice. And thanks to our back team for all their support, and thanks to you for all that you continue to do. So good morning to everyone, and hope you have a great Friday.